Alrighty, is that going to work? No? Swap. Thank you. Okay, oh yes, I can hear, everyone can hear me. Welcome, thanks for coming back after lunch. I know it's hard to do anything in the heat, and particularly when you've got a full stomach, so if you fall asleep, I won't blame you. But hopefully, when you do fall asleep, I'm going to give you some nightmares. My job today, I'm Dave, I'm an ED physician from Australia, and today we're going to talk about your deepest, darkest fears. And we're going to talk about how to deal with fear as a medical practitioner or someone who looks after patients. So just so that's who I am, I want to know who you are. So hands up if you are a paramedic. Good. Hands up if you're a nurse. Excellent. And hands up if you're a doctor. And hands up if you've run into the wrong room and you're actually meant to be on the beach somewhere. Anyone who I haven't mentioned? Yes, I know who you are. Okay, well, welcome. So now I know who I'm talking to. So a little bit about me. I am a shit magnet, which is the official term for people like me. And it's one of the reasons I've chosen ED as a profession. So you can divide medicine into Teflon, where nothing ever happens, and me, where the worst patient in the world will always turn up, and then all the complications will happen, and everything goes really pear-shaped really quickly.
Where do you work in?
I'm going to keep that quiet just so people stay away. But I realised that early on in my career, and it's followed me through, so I've had to deal with an inherent level of terror all my life and working out how to deal with this. So that's me. I want you to think about where you work. I want you to think now of either the worst patient you've ever seen or the patient that you're worried about will come in. And I apologise now that by tradition, everything I teach turns up without fail. So whatever's in your head now, you can see, and hopefully I can give you some skills today about how to deal with that. So think now, what is the patient presentation that you fear most? Because we all have them. Some people have lots. Some people only have one. I want you to think about that. Think about why it worries you and what are you going to do when it turns up, because it will. I'm going to go into that today. So what do you fear? Fear is a natural reaction to stress, and it's stress that you can't escape. And most of our jobs, just by the nature, have an element of stress. And what's stress? Well, stress is where your demands are not met by your resources, or your perceived demands are not met by resources. Now, if you work in a very large trauma centre, then trauma is usually not a problem for you. And if you work out in the bush, somewhere very distant, where you're not supported, then even one trauma is too much and can cause you an overload, can cause you stress. And then fear is your body's natural reaction to try and escape that stress. So we all have fear. And fear in medicine and in practice depends on many different things. We'll go through those today. And one of those things, I'm going to tell you about some stories, because I like, after lunch, like a few stories. So, long time ago, but not so long ago that it still doesn't matter, in my junior days, when I was a baby doctor working in a big, scary, dimly lit, a bit spooky inner city hospital, I was the intern on duty, or one of them. In those days, and I'm sure the doctors here realise that when you're an intern in a big hospital at night time, you think you're the only doctor in the whole hospital and that everyone's responsible for you. And I got called, as you often do, in the early hours of the morning to go and see a patient. So I wandered down abandoned corridors, which were obviously haunted. All the nurses disappeared, and then I walked into a room of someone, an adult, who was dying. And he was a middle-aged guy, he was in extremis, and on reflection, he was having agonal respirations and was probably in VF. But he was blue, gasping, in terror, and I had no idea what to do. Absolutely no idea. And I recognised that moment, he's really sick. That's where my medical training got me to. And then, because I'm clever, I thought, he needs a doctor. And then to my horror, I went, oh my God, it's me. And that caused me more stress and more fear and more terror. And that didn't help the guy at all because he died. So sometimes the fear comes from not knowing because you're only a baby. You're only at the beginning of your career, you haven't seen stuff, you haven't had the training yet to actually know what to do. So that's quite common at the beginning of your career. This is where I work. For those of you who don't know Australia, that's Western Australia. It's big, it's empty, long periods of travel. Sometimes I work there, sometimes I work up there, which is a very long way away, even by plane. Sometimes I work out there, depending if they'll have me, now they know I'm a shit magnet. But the big thing is sometimes I'm quite distant. And distance and being alone and not having the support you have in big hospitals can also be another level of fear. Sometimes if you're in a big hospital, you have access to unicorn juice and different types of unicorn juice and all the various specialties that you need, then the type of fear you have is different than if you're out there in a small community by yourself or with limited structure. So again, now as a senior doctor, I was up at a very tall place called Karratha, a million miles from nowhere, and as I was on call again, I seemed to spend my whole life on call, and my phone went off. It's always 3 o'clock in the morning. That's the witching hour for being on call. Woke me up. I'm not very good when I wake up. I'm not a morning person anyway. I drove through the empty, haunted town, went to the empty, haunted hospital, went down another empty, haunted corridor to find, not this baby, luckily, but a terribly sick infant. And I know we've just had a fantastic talk about neonates, but this was a sick infant, a kid with Down syndrome who was actually Indonesian, who'd rocked up in Karratha in the middle of nowhere for no apparent reason with his mum, and then got severe bronchiolitis and got into respiratory failure. So when I walked into this very scary, isolated little ED, there was a very chubby, very distressed child being croomed on the mother's lap on the bed with an Indonesian death chant, which wasn't very helpful, and in severe respiratory distress. And at that point I thought, my God, I was going to be an architect. I've made a big mistake coming to do medicine. And to help me, the child had chubby bubby hands, which always make everything very tricky, and that was just a terrible night. So you can be frightened even with experience, and I'd done ED for a long time at that point. But with isolation, you can also be quite scared. Some things are just naturally bad. Doesn't matter what you do. Now, I should have warned you beforehand, for those of you with queasy stomachs and those of you who just had a big buffet this morning, some of these slides are a bit rough. But there are some things that whatever you do, whatever your background, are going to be frightening. And part of that is because that's what we do for a living. Sometimes the worst things in the world do turn up. And that might be just terrible injuries, terrible disease. It might be things that you've never done before that you suddenly need to do, and all of a sudden you're the person that has to do it. Okay? So it might be lack of experience. One of the other things that causes a lot of grief and a lot of fear is surprise. So if we were all actually not at a conference in Thailand enjoying ourselves, we're actually at work, we're sitting there, we've had coffee, we've had some cake, we're chatting, we're looking at YouTube, we're looking at kitten videos or whatever makes you happy. I look at kitten videos. And then all of a sudden, there's a full recess. So we go from nothing to fully switched on very quickly. That surprise is something that a lot of people can't deal with. And that's often why you choose the profession or part of the profession that you're in. Certainly a lot of people, a lot of doctors hate ED. Hate it. Like, people tell me they hate it. And one of the reasons they hate it is they don't have the predictability. So you go from doing absolutely nothing to completely switched on, and that sudden change in what you're doing can be quite frightening. So again, thinking about big black hospitals, I was being big hospital this time again as a senior doctor. And this is a trauma centre, so very good at what it does. And we looked after a young man who'd motorcycled at high speed into a tree. You know, seems to be a very popular thing to do. And he was in a very bad way, such a bad way that we had to do a thoracotomy, open up his heart. We touched his heart, the blood touched the ceiling, we all high-fived. It was pretty cool. The guy died, because it often happens. We were in our element, it was fantastic. But then triage phoned through to say a woman was having a baby. This is not a maternity hospital, had no paediatrics, no neonatologists. We don't normally have babies there. The whole hospital shat itself. People were running around saying, find a midwife, find anybody who knows about babies. Get me some hot water, get me hot towels, get me a bucket. Rubber bands, I've heard about those. Put it back in, push it back in. So we'd gone from doing something that was really quite intense and really quite bad and touching someone's heart to a woman giving a normal baby coming out, which is meant to happen, and we decompensated very badly. So again, even though we're surrounded by people who know what they're doing, had lots of experience, could deal with traumas, could high-five after touching someone's heart in a very callous way, we were emasculated by the fact a baby was coming out of a mummy's tummy. Mummy's tummy, I believe that's the... No? I don't know. Now, speaking of mummy's tummies, at another hospital, again, in my life on call, I was on call for Met calls, and I got a Met call to go to the delivery suite. Now, some people were very happy to go to the delivery suite at a Met call. I was not. I'd just been watching kitten videos, and I was running down the corridor thinking, oh my God, is the mum dying? Is the baby dying? Are they both dying? Are they taking in turns? I don't know. What happened is the mum had given birth, I believe the term is, the baby was fine, and then the mum had just puffed up all over, completely like a marshmallow. And what she'd done was popped something inside and got subcutaneous emphysema over her entire body, from here down to there. Now, that's not very common, apparently, in deliveries, and certainly it freaked out the obstetricians who were sitting there with this marshmallow of a mum. Again, I had no idea what to do. But anyway, it doesn't matter where you are, whatever you're used to doing, something surprising can come along and bite you in the ass. And that can cause fear too. Now, fear is different for different people. And we're going to go through a number of different slides now, some of which will be triggering for some of you. Some of you will love things like this. This is what we call an ECG. It's not a good one, by the way. Some of you won't like the idea of using fancy medications. So certainly in adult resuscitations, we use lots of different drugs. And sometimes the fact that we have to use those different drugs, particularly if you've never used it before, and you have to do the calculations for that, that can be triggering for some people as well. It might be that you have to suddenly do a procedure that you've heard about, or you've YouTubed suddenly, or you've read about, or you're meant to know what to do, and you've never done it before. And in emergency medicine, there are a couple that always come up in our exams, so things like lateral canthotomies, where you have to cut the side of the eye to get the eyeball popping out. That doesn't sound great, but apparently it works. And then doing perimortem C-sections, where you're trying to save a mum's life during trauma. Both those things are very rare events. Technically, I'm meant to know how to do them. In practice, I would hate to have to do those unless I had a bit of a warm-up. And the other thing that we do, certainly as doctors, but I suspect as nurses and paramedics as well, is we overcomplicate our lives. I'm a very simple human being, that's why I do ED. And one of the things I hate is where we have an idea, we try and make things better, we sit down with a little project and we make a lanyard, or we make a poster, or we make some sort of guideline that ends up probably inducing seizures in about a third of the population if you're not careful. So this is a difficult airway algorithm by the airway jockeys, and to me it's not very useful. It's quite useful if you've got a beer and you can sit down and look at it for a few weeks. It's probably not very useful if you've got someone with a critical airway problem in front of you. And it's one of the things we do in healthcare. We all go off and do our little projects. You say, can you make this better? I think, yes, I can. I've got a 6-month project to do that. And then you come up with your own design and your own piece of paper, which you laminate. And if you work in any hospitals, you'll see every wall is covered with people's laminated projects from 2015 that no one ever reads again and slowly blocks out the light. So that's very normal. So we overcomplicate our lives, and that induces fear as well. And it might be the thing that scares you is the fact that certainly in medicine and adult medicine, people are getting sicker. So people are coming in, not just with one disease. It's not unusual for my patients where I work to have heart failure, respiratory failure due to pneumonia, chronic kidney disease, badly controlled diabetes, one leg has come off, they've blown a pupil and they get a rash. That's a full house. That's everything. They're walking around with organ failure. And that's not an unusual presentation for our patients. So we're not dealing with simplicity anymore. We're dealing with more complicated patients. And if we need to do something to that patient, it makes it harder. So if you do a procedure, if we need to move them, if we need to fix one thing, everything else gets harder as well. So the complexity also induces fear. And there are certain things, again, that come up rarely, that we plan for, that we think about, that turn up enough that we actually have to know how to do. And every single department I work in comes up with its own solutions. So every single department I come in with has their own trolley or their own place that they put their equipment design. It's always usually locked away. There's no standardization. And so when these terrible things do turn up, these things that can cause fear, it's harder because we haven't thought about it and everyone's going off in their own little pathway. Sometimes the things that you hate are things that you just don't have much experience with. And certainly I work in ED and critical care, so there are things that are easier for me and that may not be part of your practice. Again, the happy ECG, I see one of those every 10 minutes for an entire 10-hour shift, so I get used to those, but I do know colleagues who hate them, think that the devil's work, and try to avoid them if possible. And luckily, we've just had a fantastic talk about neonatal resus, and it doesn't really matter who you are. There is an element of fear because of cuteness. Now, my ED practice is both adult and kids. I like them both, but there's increasing cuteness as they get little, which complicates my medicine. I'm happy to do things to adults that I look at kids and go, well, you're cute. Do I really want to do this to you? And of course, there's also parents as well. And when they get really small like that, although the resuscitation pathway we just taught was actually quite simple and straightforward, there's an emotional context on that that makes little kids harder. And some people fear dealing with little kids because in our heads, they're cute and small and difficult. But in reality, they're probably simpler than we expect. These days, there is another type of fear, and that might be the direct fear. So that might be a fear of aggression. It might be a fear of abuse. Our patient population, certainly where I work, there's a lot more drug use, there's a lot more untreated psychiatric problems, and there's a change, certainly in the Australian population, of how people interact with health staff. We don't have the same position we used to have in society. We don't have the same respect that we used to have. And I think all our types of healthcare is getting affected by how people behave. And that can be very confronting. If you've gone through university or your training with the idea that you want to help people, that you want to help cute little babies, that sort of thing, and then all of a sudden someone comes in and does that, that's quite confronting. In my hospital, much to my sadness, on the day that I was off, we had a guy who was on methamphetamines, who climbed up into the roof space like this, and then ran around a bit nude. And then our security guys climbed up into the roof space after him and chased him around the roof space, and he knocked open a water main, which then flooded down through the roof across all our computers, which fritzed out. And then he fought the security guards, falling through the roof, tearing off his gastrocnemius, and arrived down on the floor and tried to stab people with electrical wires, wiping out most of our ED. It was fantastic, and I wasn't there. But for the people who were there, it was quite confronting and quite scary. And again, the fact that there are two of these guys running around means that it's actually probably more common than you expect. So physical fear of your patients, fear of your family, is often something that keeps people awake at night. And I know that my medical and nursing staff that I work with are confronted with violence a lot. And I'm sure that happens in the community too. Now I work both in big cities and out in the bush. And I know certainly for the paramedics here, your job I think is much harder than mine. I deal with big hospitals, I have a team to work with. I'm never left by myself for legal reasons. But sometimes I wouldn't have to deal with that. And I think it's much harder to do what you have to do when you don't have the support behind you. And so I don't know how you do your job where you come across this, or you're sent out to something like this, and then you have that isolation as well, contributing to the fear of what you might find. So what is fear? So fear is important. I always worry about people who say they're never frightened, because then they are deluding themselves. They're obviously missing something. And I think it's healthy to have a level of fear that is not paralysing, but allows you to realise that what we do actually matters. And for the rest of the talk, I'm going to talk about how to adjust that fear so that you're not paralysed and you can use it to actually make your practice better. So what does fear do to you physiologically? Stress and fear, a bit of a continuum. So as you get stressed, as your demands are outstripped by your resources outstripped by your demands, your adrenal gland starts to squeeze, you get cortisol and adrenaline, your heart rate goes up, blood pressure goes up, your pupils dilate, your mouth goes dry, you start to shake, and your hand-eye coordination gets worse. Because your body is trying to get away from that danger, or that perceived danger, It's either going to fight, punch it in the head, or it's going to run away. And both of those things we can't do when we're seeing patients. But all those physiological changes that happen when you're scared reduce your ability to do your job. You don't think better. You can't do fine motor details for procedures better. You try and cannulate someone when you're shaking, it's hard to do. And there's an avoidance as well. If you're always worried about going to work, if you're worried about that patient you thought about at the beginning of the talk, then you might avoid it. You might not want to go to work. You might try and avoid seeing those situations when you are at work. And that can change the way you practice and the way you enjoy work and progress in your career. Now, stress is useful. It helps to concentrate your mind, particularly when you've got someone who's very sick, who needs you to be on your game. But repeated stress without relief, repeated stress over and over again, leads to anxiety and depression and burnout. And these are things that are very common in all our professions. So there are some things that you can actually do. Finally, one of the other major concerns I think that people have, another fear, is fear of either not knowing or being seen by your colleagues that you don't know something. Now, I'm an ED physician. I've done this for a while now. I should know stuff. I've passed lots of exams. I've got a few positions here and there. And when I'm running resusc or I'm seeing a sick patient, people look to me and say, oh, Dave's here. He should know what to do. And some of the time I do. But it's not unusual for me to come across something and say, I have fucking no clue what to do. I don't know what this is. And I think it's really important to recognise that you can't know everything and to be in a system that allows you to say, I don't know. And one of the reasons I like my department is that people are happy to say, I don't know. I don't know, I need to ask. We talk amongst ourselves. We say, what do you think of this ECG? What's normal potassium? What's the dose of this? How many legs do people have? You know, all the usual questions that come up during a course. So don't be afraid to not know or to be thought to not know. Okay, so how do we reduce fear? And I can divide this into things that you can do and things that your practice, the place that you work, might be able to change to reduce fear, and things that our health system, the health systems that we work in, might be able to do. So one of the things that I do when I'm faced with fear is firstly just recognising that this is a stressful situation, I'm being taxed by this, it's starting to affect me, or I am actually frightened of this illness or this presentation. And hands up, have you heard of square breathing? Some of you have? Okay. Something that athletes do, something that people in the military do when they're about to shoot someone. So it naturally goes into medicine. So I want you to all take a deep breath for 4 seconds. 1, 2, 3, 4. I want you to hold it for 4 seconds. 1, 2, 3, 4. Breathe out for 4 seconds. 1, 2, 3, 4. And hold your breath for 4 seconds. 1, 2, 3, 4. Now, breathe normally. This is what's called square breathing. And if you do that enough, it actually resets your physiology. It reduces your heart rate. It reduces your stress response, and it can actually centre you if you're in a stressful situation. So there are some things you can do to change your physiology if you're faced with fear. The other thing I always do is sort of longer term, and things like making sure that I've had some food, that I've come to work with some adequate sleep, that I've had breaks, and looking after myself, if I've got a resus, that I've gone to the loo, all those things to make things a bit easier when the shit hits the fan, because it's always going to do that. So, there are some things in my practice, in my lifetime, that have made things easier for us, certainly as doctors and probably as other health staff too. And I like to think about ABCDs, as we always do. Again, I'm a simple human being. Now, from an airway point of view, if you have trouble oxygenating, trouble ventilating someone, these days you have LMAs. And they're amazing devices. For the people that you can't oxygenate, you can't ventilate, the vast majority will improve if you shove one of these down. You need minimal training. They work all the way down to neonates. They're fantastic. They're well designed. They take away the fear of an A problem. Okay? Now, no, not all fear, doesn't cure everything, but reduces the number of times you have to worry about A. From a breathing point of view, it's non-invasive ventilation. So CPAP and BiPAP. In the distant past, but again, not so distant that it's not relevant, when I was a baby doctor, if you had acute pulmonary edema, you get intubated. If you had infective exacerbation of emphysema, you get intubated. And you die because you're crap. And you never get better. And these days, because of NIV, we put adults onto CPAP and BiPAP all the time. We rarely intubate them, and people get better. So from a B point of view, NIV solves lots of B. From a C point of view, it's all about getting access. There's very little that you can do if you can't get a drip in. And there are people, for whatever reason, that it's hard to get a drip in. Either they have no arms or legs, their body habitus doesn't allow it, they're severely needle phobic, whatever else it is, or they're 90-year-old IV drug using diabetic, dehydrated little old ladies, and you can't get a drip in when you need one. So luckily, we've gone back to the beginning and said IOs are fine. Intraosseous are easy, they're quick, they give you access when you need it most. And it takes away the fear of not being able to get IV access in your sick patients. So C is often sorted out by IOs. And the other type of C that we've changed in my department is that my junior doctors had problems with people who were septic. They were septic and they were shocked and they needed resuscitation, and they're quite junior and they couldn't put central lines in, so they gave fluid. And there were cases where they'd have someone who'd septic shock and they'd give 1 litre of saline. And then they give 2 litres of saline, and they give 3 litres of saline, and they give 4 litres of saline, and they give 5 litres of saline, and they give 6 litres of saline, and they give 7 litres of saline, they give 8 litres of saline, at which point the patient arrests. And we realised that that wasn't a good thing to do. And part of that was the fear that they weren't able to use vasopressors when they needed to. So we changed our approach. There is evidence there that you can use peripheral vasopressors quite rapidly, easily, and safely in the vast majority of patients who need them. And we will come in and help put central access into the patients who need it when they're resuscitated. So that's C. And D is ketamine. Who likes ketamine? Ketamine is an amazing drug. It should be in the water supply. It fixes almost everything else. It probably is here, to be fair. I don't know whether you've had any of the water out of the tap. But ketamine fixes other problems as well. It's fantastic analgesic agent, fantastic anaesthetic agent, and it's a bronchodilator. It fixes almost everything. I think ketamine's amazing. Now, hands up if you love maths. You know, there's some nerds here. Okay, I hate maths, and I'm not very good at it. And I don't mind resuscitating kids, but I hate the math side of things. And to have a really sick kid who's cute and worried parents and worried that you have to do stuff, and then having to do maths on top of that was a big fear of mine. And it limited how I enjoyed paediatric resuscitation, which should be really enjoyable, to be fair. So now, luckily, you guys that work in the future, you don't have to be maths geniuses. There's stuff online, and in my region, the local kids hospital has a free online drug calculator, which I get someone else to go and do. So if I'm running the resus, I say, do you mind going and printing out the resus drug calculator and bringing it to the bedside? You put the weight in, everything else comes up, so I can decide what to give, but I don't have to do the maths to work out how much to give. And that mental decompression is one of the reasons that it's much less scary to deal with kids now. You know, as was said before, most kids don't need complex stuff. They just need some stuff, but they need a small amount of stuff. And if you've got someone else doing the maths for you, it means that you'll step up and resuscitate and do the simple things the child needs and not get too fearful of it. So again, another way of reducing fear. Now, this is a picture of hematemesis. And I will tell you, it's a cartoon picture of hematemesis because it's very, very difficult to find a real picture of someone spewing up blood. That's not on a very specific dark website. So this is the only one I've got. The reason I put it up there is when I graduated, when I became an ED physician, one of the things that still worried me a lot was how to deal with people hosing blood out the top end. We do see it. We see hematemesis, we see hemoptysis. In kids, we see the post-tonsillectomy bleeds, horrible stuff. So they're hemodynamically unstable and they've got really tricky airways as well. And that worried me a lot. That was one of my fears. So one of the ways to reduce the fear of the thing that you thought about at the beginning of this talk is to mentally think about that and what are you going to do when it comes in. And be very specific about it. So I've thought, if I have someone with hematemesis, I'm going to call for help first. I'm going to need dual suction. My airway is going to be tricky. I'm not going to be able to use a video laryngoscope because it's going to be covered in blood. I'm going to use a large sized tube. I'm going to need someone else to do fluid resuscitation at the same time. And I've got a different sequential way of getting that airway if I need to, if it's full of blood. And I've thought through step by step by step in my head of what I'm going to do when that turns up. Now, naturally, because I've done that, that turns up all the fucking time. As every second shift, I have someone who's hosing blood on the ceiling, on the floor. It seems to be the world centre for coughing up blood at my ED at the moment. So this is a really shitty picture. It's of simulation. So one of the other things you can do to help yourself and then your team as well is to do simulation. And simulation medicine is a whole other topic to talk about. Hands up if you do sims where you work. So we do, okay. It's really useful. And part of that is to reduce the fear of those things that you should know or you might not know, and how to practice and practice and practice and practice so that you get some muscle memory, that you've gone through it in your head, you've gone through it as a team, so when it does interrupt your kitting and watching videos, you've actually gone through it in your head and it's not such a surprise. So you reduce the fear by exposure over and over and over again. And that's one of the things that I think helps reduce fear as a person. That also helps in the place that you work. So if you are working in a big hospital, in an ED, I'm sure you have simulation there. If you're working in a nursing post with only a few people, if you're working in an ambulance or paramedic substation, think about the people you work with, and you need to practice with them for the bad things. So the first thing you need to do is work out what comes into your place that you work that would cause fear. What things cause you trouble? And it might be, if you're in an adult hospital, how are you going to deal with a sick kid? If you're in a kid's hospital, how are you going to deal with anything adult? If you're in the remote communities, how are you going to deal with anything that stretches your resources? So think about, what do you see, what aren't you equipped to deal with easily, what's going to tax your resources, and then train and train and train and train, and make sure that as a group, things get a bit easier. So resuscitation is fun, but it's much more fun with friends. And if you get to work with other people, then work with them so that they know how you work and you know how they work, and you practice and practice and practice. So simulation is really important. The other thing that you can do as a group in the place that you practice is simplify. So look at your pathways, look at how you do things, and see if you can simplify them. If we go back to that anaesthetic difficult airway, that's probably technically very correct, possibly evidence-based, but completely useless if things are going pear-shaped. And it's not unusual for EDs, and I think other forms of medicine, to have many, many copies of different pathways on different fonts with different squiggles on it and different lines, none of which are easily accessible. And if it's too complex where you work, it's because it's been built up over years and years and years. Someone's got a new job, they've redone it, and they're just stuck onto the wall, and it's another piece of paper on the wall that no one ever reads. So go back to basics, think about what you do, think about what's difficult, and as a group, try and simplify your approach. And that might be, how do I get help? What's the quickest way to get help if you need help? If you're in a place that needs to get blood, how do I get blood really quickly? And if you're in a place that needs to refer patients elsewhere for care, if they need to travel the 2,500 kilometres to your major city by plane, how do you get someone to pick up your patient? How do you make it simple? Now, unfortunately, in healthcare, we all work in our own little silos. So in Western Australia where I work, or in Australia where I work, every state has its own health system. Every town has its own health system. Every city has its little divisions. Every hospital has its own little wards and departments, and no one really talks to each other. And certainly in Western Australia where I work, there's been an increased attempt to try and get patients moved from one place to the other without lots of intervening bullshit. And that actually hasn't worked. There's more phone calls to make. There's more layers of stuff that you have to go through. And if you're the referring doctor, nurse or paramedic out there by yourself with the worst patient in the world, that makes things much harder. So one of the things your system can do to reduce fear is to simplify what you do. And that really leads into the idea of how to fix a health system. to reduce the fear. And part of that has to be a system that is, again, happy for you to recognise your limitations. Happy for you to say, I don't know. Be very open to say, I don't know what to do. I need help. I need to get some advice. I need to talk to a colleague. And not assuming that because you're in the position that you are, that you know all of medicine, all of nursing, all of paramedicine. And we have to change in a society that we don't blame individuals for when things go wrong. We work in a very tricky environment. It's often very unstable, and there are repeated times where individuals have been focused on when something happens, when something bad happens in the system. So we need to change that system to support the idea that things are scary, that you don't know everything, and not everything is easy for everybody, and change that. We need to also have a discussion with our patients and the community to change the expectation about things like litigation, so that when things are challenging, when things are difficult, when things are scary, that the immediate response isn't always to go towards litigation. And I think that pressure, certainly in some environments, I believe, in the United States in particular, and Ireland as well, very litigious, a very hard place to practice, where that's always over your shoulder. And that's a discussion that you have to have with your community. The big thing, and I suppose the takeaway message from all of this discussion today, is that you are practicing essentially in the future. Most of you will have one of these in your pocket right now. Some of you will be looking at kidding videos on them while I talk. But you can talk to anyone, anywhere, 24 hours a day. You can ask for help. And anyone you call will help you. You can look up things online. You can look up guidelines. You can look up doses. You can look up procedures. You can Google it. You can YouTube it. You're never as alone as you think you are. Now, when I was writing that, I hadn't thought about where I work. Certainly in Western Australia, there are places that don't have mobile coverage, so that doesn't go for everybody. But the vast majority of people will have access to the world in their pocket. So the nature of medicine and of medical practice has changed. You now have supercomputers in your pocket, and you can actually contact everyone. So I wanted to talk about fear today, and fear in your practice, because I think it's very common, and I think it's hidden away. And a lot of people will hide it down, because it's a sign of weakness, a perceived sign of weakness. But I think it's a problem where you don't recognise that things are scary for you, and then you don't go and look at ways of changing that. Now, if you can harness that fear and change that fear from fear into just stress, and stress into opportunity, then it'll actually be a good motivator for giving good clinical care. So the one thing I want you to do today, the one thing to take away from today, is go back to the beginning of the talk about the patient that you imagined, or the scenario that you imagined that scares you. And I want you to think about how to solve that problem. If you take away anything from today, how are you going to face that fear? What are you going to do? And that might be getting more knowledge. It might be talking to a colleague. It might be going to a course. It might be learning how to do a procedure. It might be changing the way your practice works. It might be getting access to different equipment. It might be doing simulations. Whatever it is, face that fear that you've got in your heads. Because if you don't, it's always going to be there. And after this talk, it's going to be there next week. So take this opportunity to actually change something in your practice and improve it. And I think that will make things a bit better. Anyway, I think that's all. So thank you very much for your patience.
Does anyone have any questions today?
Yeah, well, you're more at Perth.
Yes. You could pick it up. That's bad. Nothing else? You're all drained, dead? Fine. Lovely. Thank you very much. Thank you.